So the next thing I wanted to talk about is really sort of the basic concepts of treating prostate cancer. And so this is sort of just a little outline of, some of how, prostate cancer sort of operates and the hormonal, signals that involve prostate cancer growth. So what we have here is basically the brain, which sends a signal to the testicles that helps produce testosterone. And so we know, and sort of the backbone of our treatment for prostate cancer, in later settings, and also sometimes in the localized setting, is the prostate cancer feeds off of testosterone. So the way I explain it to folks is that we want to sort of cut off the food supply to the prostate cancer, which is testosterone. So if we decrease the testosterone level, then we theoretically stop the growth of the prostate cancer. But there's obviously other things that go into that as well. And so that's why we add additional treatments that we'll talk about as well. But this is sort of the basic concept of trying to stop testosterone production. And so when we talk about, who are involved really in making all of these decisions, I think there are a few different folks that are part of this team. So, the urologist is typically the person that's doing the biopsy. If you're going to have some type of surgery where they're removing the prostate, this is the person that will do it. You'll have the medical oncologist like ourselves that will talk to you about hormonal treatment, about chemotherapy, about targeted treatments potentially. The radiation doctors are different than us in that they are also cancer doctors, but they focus more on the radiation piece of things, which is very different than chemo or hormonal treatment or targeted treatment. And then we have a radiology doctors who interpret those scans that we talked about, the pathology doctors that look under the microscope and help us make a diagnosis of the prostate cancer. And then really, most people are seeing their primary care doctor and talking about, doing a PSA screen. So that's really where a lot of these conversations start, really. And so, going back to treatment, like we have sort of talked about for the most part, treatment really depends on the stage, the Gleason score, and that, score of 6 to 10, and where sort of people fall within that. If it's more aggressive, then we may have to do a little bit more aggressive treatment as a result of that. The PSA level, the higher it is, the more likely we're going to have to do an additional treatment in terms of hormone treatment or radiation potentially. And then also, if there's lymph node involvement or other organ involvement, that sort of changes. We would consider that maybe, stage 4 at that point, and that we would have to discuss other types of treatment as a result of that. Comments about the treatment aspect of things.
Yeah, I mean, I think the only other thing I would add is, apart from our treatment teams, the nurse navigators and the nurses and the whole medical staff that we have, it almost takes a village to help someone go through their treatment. So, those are patients' sort of best resources and their point person to sort of contact if they are having any troubles. So always keep them in the loop, But yeah, I think this is a great summary so far.